I want to show you something very, very, very interesting. So once we do the laparoscopy, we know that the patient had a rectovaginal nodule because it is obvious. We find the segment, the infiltration of the vagina. So this is the nodule of the rectum. Here we have the hydrosalpinx. It has been seen. And as I told you, I saw also a sigmoid colon. So let's look at the rest of the colon. Here we are very happy. We have anything you wish to operate, but let's go on the sigmoid colon. The sigmoid colon looks normal, okay? But as I said, I saw a nodule. Let's go a bit upward and look what I see. This is a subocclusive nodule of the sigmoid colon. And you know that the colorectal nodule are more or less two types. The rectovaginal nodule with infiltration of the rectum, and the second type, which is very, very dangerous, is the solitary sigmoid colon, which are not adherent to uterosacral ligaments or to ovaries, and they can be missed very, very well if the surgeon is not aware that they exist. Because like this, someone who comes performing the surgery said, I found the hydrosalpinx, I found the rectal lesion, which explains the digestive symptoms. He performed the surgery, and within 2 years, the patient will have an occlusion due to this one, which was completely missed. Okay? Now, let's go to the surgery. So we'll start by ureterolysis. I have already done it on the right side. Now, we'll do the left side ureterolysis. We'll try to restore the fallopian tube or to remove it. And then we'll proceed to the excision of the rectovaginal nodule by opening the Okabayashi space on each side, sectioning the nodule in two pieces, one of the rectum, one of the vagina. We excise the infiltration of the vagina uterosacral ligaments. Then we will shave the rectum to see if the disc excision is feasible. And if it is feasible, we do the shaving. Then we go to perform the segmental resection of this nodule, and we'll finish by the disc excision. Okay, so this are the steps. And at the end, we will, or before the segmental resection, we'll dissect the left sciatic nerve. Okay? So, a very ambitious program. Now, during the surgery, you can ask any question. My idea, my suggestion is that people in the room ask the question, and then it is the question is repeated by the chairman, because the sound we received is very good when the chairman speaks. It may be less when you use microphones in the room. Okay, please. So let's go on the fallopian tube. We said that either we restore the fallopian tube or we remove it. We have already done the tubal patency test. We had some blue liquid through the ampulla, but we have to see how the fallopian tube itself presents, because there is no advantage to leave a fallopian tube which is not okay, and then within 2 months my colleagues from ART asked me to redo the surgery to remove the fallopian tube, because the hydrosalpinx is back. So let's see how it presents. Leave it. So we have here the infiltration. Here we have the ovary. Here it's a bit thick. So the patient is 40-year-old. The over fallopian tube is very well. She has 2 embryos, 2 frozen embryos. I will suggest to remove it. Do you agree or not? How many among you would keep it like this? So I recall you. Patient has 40-year-old. The fallopian tube is open, but after the surgery, once we do the surgery here, I think there is a high risk to have a new adhesion and obstruction, so I think it's better to remove it. Good morning, how are you? I'm very fine. Now we are in contact, I am very, very fine. And I want to send our greetings to all our colleagues from Israel. I know many of them. And we have built during the last 10 years, a very nice friendship between our team and the Israeli community of gynecologists. So it is actually a great pleasure to be with you this morning. I do not understand. What's the audience. Yes, yes. Okay, perfect. Yes, so actually I use the air seal because the air seal allows me to open the vagina and to work with vagina opened without any loss of pneumoperitoneum. So for these complex surgeries, I think it is actually a great advantage in laparoscopy. In robot, I also use it, but less, because in robot I have the arms, robotic arms, which are very strong and hold up the the abdominal wall. But in laparoscopy, this kind of surgery with air seal is actually a huge advantage. So let's go close. Here we have the ureter. And we need to dissect the ureter far until the cardinal ligament, because we'll have a big piece of the vagina to remove. And it is very important not to come with our instruments which may diffuse heat, not to come on contact with the ureter. So the ureter should be dissected very far. And as you can see, my instrument, my grasper, push laterally the ureter, and while my HD1000, this is the harmonic scalpel, is performing the section and the coagulation. So now we have this situation. Now let's go farther and to attack the Okabayashi space. Hold this, Matan, please, and push toward you. Okay, I can suspend the ovary. Maybe I will suspend it because just I will see. Maybe not. So come far. So here, what is important to identify the hypogastric nerve and to avoid to cut it. So it comes from the superior hypogastric plexus and goes, I think it is here like this. And it goes joining the inferior hypogastric plexus. The hypogastric nerve is a sympathetic nerve, so it is not responsible directly from bladder voiding. So if you cut it, you won't have bladder voiding trouble, but you don't have a bladder atony, but you may have some difficulties to feel if the bladder is full or not. So the bladder troubles are much more discreet and subtle. anyway, we have to preserve it when it is not infiltrated by the disease. Unfortunately, that may happen frequently. So here we take the contact with the rectum. We will remove this piece like this, and here we continue with the rectum. You see the rectum is here. Yes. I'm fine. And how are you? There is a long time we have not met together. Get back. Back. Yeah, so yes, I always ask them if they have bowel voiding troubles. And if they have, sometimes I also do a urodynamic test, but only if the bladder voiding trouble is obvious and more or less continuous. Because if the bladder voiding trouble is subjective only during the periods, it is very difficult to reveal it on the urodynamic test. And in this case, if you do a urodynamic test and it is normal, but it means that the postoperative bleeding voiding problem is exclusively your responsibility. So I mention I do simply ultrasound to see the post-voiding bladder volume, which is usually normal outside periods. Come, I want to wash you. Come close. Okay. And then I inform them that the risk of bladder voiding troubles is significant after the surgery, because the dissection of the nerves, the anesthesiology, the edema, postoperative edema may impair the bladder function for a couple of weeks or a couple of months. So in this case, I told her that she may risk to have self-catheterization maybe in 10 to 20% of cases, but for sure the bladder catheterization will be, self-catheterization will be transitory, because we will completely conservate the nerves on the right side, and I imagine we'll conservate them also on the left side, at least partially. So, sorry? Even though they are part of disease already. Yes. But you have to know that we have a lot of patients with we have patients who come with self-catheterization before any surgery, because the disease has already impaired the bladder function and infiltrating the splanchnic nerves. And this situation is dramatical, because it is very difficult to restore the function when the nerves are actually infiltrated on both sides. So in this case, it's usually the patients will do not longer have pain after the surgery, but they will have self-catheterization for the rest of their life. That's why it is important, when the patient has bladder voiding trouble, to not to postpone too much the surgery, because the surgery may become useless. Now let's go on the other side. Put your instruments here, please. So I continue to go down on contact with the rectal wall, which is white. So I take the contact with the rectum. Here, you see, it is here. And I want to find the rectovaginal space, which is safe below the nodule. Okay. So I told you that the infiltration of the vagina is huge. Yeah. I'm fine. How are you? Yes. The explanation is very simple because you asked me to perform a surgery on Monday, and on Monday I do not have the robot. And also I understood that for you is more interesting to have a laparoscopic surgery than a robotic surgery because I think the laparoscopy is much more frequently used employed in Israel. So I choose to do a laparoscopic surgery. But even though now I do this surgery with the robot, I have done it maybe threefold more procedures in laparoscopy. So for me, it's not a problem. But for sure, now I prefer this surgery. I prefer to do it with the robot. So this surgery today is laparoscopically for you. Okay, so now I think we have an idea about the infiltration of the rectum, which is huge. I think the disc excision will be very, 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 very challenging. We'll try to see if we can do it because I think it is important to spare. I will wash the camera. Come here. No. Inside. Don't bring the camera out. We do it inside very well. Put the drop here like this. Okay. Now let's see where is the rectovaginal nodule. As I told you that the vagina infiltration is huge, so the rectovaginal nodule should be here. Okay, it's here. So here we have the rectum, here we have the vagina. Here is the rectum, and here is the rectovaginal space. Yeah. So the patients who have who are destined to have scheduled to have a rectal surgery, they have 5 days residue-free diet. Then they have 2 days and 1 day before. They receive clean prep, pico prep, so the solution to drink which cleans the bowel. And then the evening before they have a normacol, meaning an enema. And with this, we can perform safely our nose procedures, meaning natural orifice specimen extraction, because you will see here, in theory, we will not open the abdomen. We do not longer do the suprapubic incision, because we will use the vagina to introduce the anvil and to take out the specimen. So this is the natural orifice specimen extraction or nose. And we published a series of 50 cases 3 years ago, I think. And now we prepare another article with more than 300 cases where we compare the outcomes to the classical resection through the suprapubic incision. And we observed that we do not have more infections or fistula using this approach, even though we most likely have more contamination of the abdomen because the bowel is opened inside. Now let's see the size of the infiltration. I think it can be. I think we can do the disc excision. I think we can do the disc excision. This is very well. So let's go now to excise the uterosacral ligaments and this nodule of the vagina. to do this, hold this please. To do this, no, let it down. We will come from here to there to join the incision. We'll open only the peritoneum to spare the hypogastric nerve. The hypogastric nerve should be here into the depth. It should be here into the depth. It is here. Just a moment. Can you clean the camera on the uterus? Just a moment. Yeah, so the hypogastric nerve is here. You see? Here, white in this opening. So we will cut medially in order to preserve it. So even though you see it through the peritoneum, when you pull on the peritoneum, it is not adherent to the peritoneum. So you can afford to open the peritoneum like this and to preserve the nerve. Like this. Okay. And we'll remove this because it's peritoneum which is a bit sick and which is adherent to the anterior root of the right uterosacral ligament. Yes. For ureters, yes, but only when I do, but it depends, what do you want to see with the ICG? Where is the ureter, or if the ureter vascularization is preserved? Because I have colleagues who inject the ICG into the ureter in order to see it where is, and I do not need because I see it enough. And other colleagues like me, we inject the ureter intravenously in order to see if the vascularization of the ureter, clean please, on the uterus. Yeah, it's okay. So I use it only to check the vascularization and not to identify the ureter itself. Because I think we see it very well. I don't need... But I know... who told me this? I think Abhishek Manjeshikar was here 2 weeks ago. And he told me that he used to perform a cystoscopy and to inject the fluorescein indocyanine into the ureter to see where is the ureter. I think I don't find it very useful in a majority of cases. Maybe sometimes it can. This will leave because it's okay, and we'll come here. Yeah, of course. I completely agree with him. The problem is that I cannot do it with this. I cannot do it today because we do not have ICG on this laparoscopic tower. So I systematically bipolar. I systematically do it with the robot, but in laparoscopy I am not yet able to do it because the clinic told me that buying this. Column, the Rubina, come here, put your, is on the to-do list, but right now, today, is still on the to-do list.
So nice to see that you have the same problems as us. You don't know.
But I think we still have the same problems because as this technology is very, very expensive, you cannot afford to buy it yourself, and you depend on a planning of expenses of the facility. It is much easier, I think, now in a private clinic to do this in France than in a public hospital. And but 7 years ago we bought this tower, 3D tower. Last year we bought 4K tower, but me, I work only on 3D, not in 4K. That's why I don't use, I prefer to use in 3D than to use the ICG. So I extensively use the ICG with the robot and not in laparoscopy, unfortunately. So here we will finish by antevert uterus, very, very strong. So now we'll come here to try to delimitate the nodule from the uterus. Here you see we have a lot of vessels, so you can expect then it will bleed at the moment. Yes, we have veins here. So and here I will put the finger into the I will just progress a couple of millimeters, and then I will put the finger into the vagina and I will direct the dissection with the finger. And this I do it routinely in laparoscopy. I cannot do it in the robot, so my my approach, surgical approach, is different in robot, where I use exclusively what I see, from laparoscopy, where I extensively use what I feel with my fingers. Okay, let me see now. Bipolar, I will finish the hemostasis here at this level. No, don't pull it, don't, because they are only vessels, and just pulling them may lead to hemorrhage. I will just treat them very, very respectfully on site. Okay, very well. Now let's go on the camera. It's a bit turned like this. So I put a don't retroverse. Stay as you are. So here is my finger. Here we have the nodule. The ureter is far. It is there. Okay. So I look for my finger with my blade. Now the uterus, for sure, it has adenomyosis, and this adenomyosis is continuous with the nodule. So the excision on the side of the uterus is not complete. That's why I suggest not to dig too much into the uterus in patients who wishes to get pregnant after, because we may have a very bad surprise during the pregnancies, and you have already seen for sure articles about uterine rupture in patient with previous. Now I change the gloves and I come with my hand on the grasper, because I know the vaginal cul-de-sac is here, so I can open. Put the air seal on high flow, please, because I will open the vagina. So here we are behind the cervix, and you will see We'll open the vagina very soon. The suture of the vagina is difficult, so reinserting the vagina on the cervix is not an easy task. But we have to do it. We cannot leave this vagina like this, because the endometriosis develops maybe from originates in this infiltration. And second, the patient has deep dyspareunia, so we cannot afford to leave it like this. Okay. So this is the infiltration of the vagina. Here is the vagina opening. And you see we are on the cervix. Here is the cervix. Yeah, stay in the middle. Don't come close to the... Here is the cervix. Don't come close to the ovary in order to avoid to put blood on the from the ovary on the camera. So here is the infiltration. You see the infiltration of the vagina is obvious. Here you can see a black cyst, showing that we actually... Qua? Wait, photo. Just a moment. Yeah. Here we have a black cyst, which shows that indeed it is endometriosis and nothing else. Okay, now we come here. So here what is the most difficult step is to identify the Okabayashi space and then to dissect the rectum away from the vaginal infiltration without injury it. And this step is difficult, huh? And I think it's the step which makes the difference when you see someone performing the surgery. Depending on this step, I understand if my colleague is experienced or not in this surgery, because depending on the experience, it may take 5 minutes or 1 hour. And it is, I think, more challenging than the colorectal resection itself, which is more or less a classical and standardized procedure. Okay. Okay, so here we finish, and then we'll carry out the hemostasis. So this is the vaginal infiltration. Vaginal infiltration with a piece of the nodule. I think there or maybe 60% of the nodule. Can you clean, please? I try not to move very, very fast, because I imagine you have already had the breakfast. And I don't want to be nauseous because of my surgery. So I will put the nodule inside. And my second assistant, who comes from Turkey, will hold it, not right now, but in a couple of minutes. Okay. We will wash. And we'll do the hemostasis. Bipolar. So I always push the uterus laterally. The ureter laterally, I want to say. Yeah, yeah, this is the behavior. I use 0 degree in laparoscopy and 30 degree in the robot, with the robot. Why? Because of my placement of trocar. So I place the trocars like as the team of Clermont-Ferrand taught me. So I have a trocar, an operative trocar on the midline, 8 centimeter below the umbilicus, this one. If you have a 30-degree trocar, to see here, you need to be there because you see it down. And I have continuously conflict between this third instrument and my trocar. That's why I don't use it in laparoscopy, only in robotic surgery. Now let's go to see, which is important is to see now if we can do a disc excision or not. And to understand this, we'll put a probe into the rectum, and I will clean the rectum. I will clean the rectum. Don't let it down right now. Wait, don't let it down. Wait to have the probe. And take this. Hold this out. We'll take the nodule out. Huh? Yeah, and the fallopian tube I will get. No, less uterus. Don't touch the uterus. Yeah. It's on the right side. Okay, hold it. No, just one. Stop. You can it? Okay. You hold it? Perfect. Now let me take. Where is the fallopian tube? It's in the front. Can you also take the fallopian tube out? Oui, hein, dans un gant. Hein. Just a moment, I will untever the uterus. If you get down the uterus, I cannot help you. No. It is on the right side again. So if you can hold it, untever the uterus. Okay? Perfect. Now, I just to do something, I will open a bit more the rectovaginal space, because as I have a vaginal suture, I need to do it correctly. Now come here, hold the rectum, but very, very gently, Matan, very gently, and put it on the midline and up. So we open the rectovaginal space because we need to reduce any tension on the rectum, but also on the vaginal suture. Otherwise, there is a risk to open it. So you see, we have here the rectovaginal space. Here is the rectum. Here is the vagina. Okay. Yes. It's a very good question, and I have no answer. So we made a study on the Syria we had in Rouen. Unfortunately, the resident has never finished by an article. And we observe that when we take the decision to do the cesarean section, everything works well. When we take the decision to do a delivery, vaginal delivery, in a half of cases, they have vaginal delivery, it works well. It means that the decision, in my opinion, should be taken at the end of the pregnancy, when the obstetrician should check the elasticity of the vagina, because if the vagina is very rigid, of course we may have dehiscence of the vagina. So conversely, if we have a suture of the rectum below 5 centimeter high, I suggest to have a cesarean section in order to avoid. Yeah, you can put it into the rectum. I suggest to have a cesarean section in order to avoid any injury of the anal sphincter. Okay, down, 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 down. Yeah. Yes. Perfect. Ah, we have a big nodule. You see, it is it is into the it is protrusive because just a moment. You have to put it down, down like this. Okay. Like this. Okay, hold it like this. Because look how here it goes up. It means that it is very rigid, and pushing here get to the to a movement of the wall infiltration. So to make sure that we can do a disc excision, we have to dig into the nodule to see if we can do a deep shaving. Okay, let me see. Yeah, here there's a protrusion. We cannot, it is obvious that we cannot do a disc excision to remove the nodule itself. It is actually impossible because the transanal stapler cannot go through this stenotic area. That's why we have to dig into the nodule and to leave a very thin rectal wall with no stenosis. And that's why also if you do a combined rectal disc excision and a segmental resection, we have to start by the segmental resection, because once we do the disc excision, when we have a suture of this large area, we have to avoid to push another stapler inside to go on the sigmoid colon. So the rectal disc excision, if we do a disc excision, will be definitively the last procedure of this surgery. But we have to make sure that it is feasible, because if it is not feasible, we have to cut again in order to carry out an unblock rectal resection. So we start by carrying out the sigmoid colon, you see, endometriosis, we open the cyst. So we start by the sigmoid colon resection, but there is a risk to come back to cut again the colon in order to redo and block large rectal resection if the disc excision is not feasible. That's why I need to make sure that we can do it. And as you know, as you see, once I start the disc excision, when I start the shaving, the area, don't pull too much, because it may leave it alone, because there is a risk to break it. You see the area of the infiltration increases, and I think that the disc excision will be problematic. Now, we have to cut here. Once we release the nodule, we see that the level of infiltration is not as low as we expected. So I think if we do in unblock rectal resection, we can anyway conserve 8 centimeters of the rectum, which is a good thing, because it may be enough to avoid the low anterior rectal resection syndrome. So when we perform rectal endometriosis, my first goal is to avoid a long time Lars syndrome, so low anterior rectal resection syndrome, because it is terrible to have functional troubles after this surgery in young women. And not earlier than yesterday, I saw a patient with a long rectal resection I did in 2016 in Rouen, and she developed a Lars after the surgery, And now she came back to see me because we have to do a hysterectomy. And when I ask her about the bowel function, it starts being bearable 9 years later. So we have to pay attention to this problem, which are the functional troubles after rectal surgery. Now, if you want to treat separately, the disc excision should take from here to there, and in my opinion, it is too large. The question you can ask is if we can do a segmental resection here, then to conservate all this bowel and to do another segmental resection here. But if you do this segmental resection here, we have to do it shortly. If you do it shortly, we cannot actually do it with a transanal stapler because the transanal stapler is not long enough. In this case, it means that we will do it by suprapubic. Look at this. This dilation shows the degree of the stenosis. So it is actually a subocclusive nodule we have here. Just a moment. Yeah, photo. Okay. Could you call Barbara? Let's see with Barbara if we can afford to do a short short segmental resection here and another one here. Call Barbara, please. Huh? Okay. Barbara is the colorectal surgeon. Very, very nice colleague. Very good. So let's prepare. Tell her that I need her to come here to see what I'm doing and to discuss. Okay, I start to prepare anyway the mesocolon, mesorectum. Put your instrument here like this, please. Okay. She has a patient in OPD in consultation, so he'll come within 10 minutes. So until 10 minutes, I will prepare the mesorectum. And then what we can do is to go on the sciatic nerve. And anyway, we'll finish by the rectal procedure. How long time I have for this live surgery in order to prioritize the procedure I can show you? 1 hour more. Okay, very well. But you won't see the whole procedure, but what I can do is anyway I record everything, so I can put it on my on YouTube channel and on my Facebook. So it's simply, if you connect on, you can see the end of the procedure, which is not shown on live, if you wish. Okay. Now, Matan, please push the bowel here like this, because I have to come here to prepare the mesorectum by here. So I'm cleaning the bowel, and I will cut the mesorectum. And then, depending on what Barbara decides, if she say, okay, we can do a separate segmental resection, I will cut the rectum. And if she said we cannot, but we'll continue with the section of the mesocolon and mesorectum up to the second nodule. But this, what I'm doing, is anyway necessary, whatever is the procedure we ultimately decide to do. But the surgery is anyway required, so no regret, because of the proximal nodule, which in my opinion is subocclusive. You can remove the rectal probe, my friend. Remove the rectal probe and continue to antevert the uterus. Yeah, so here we have the mesorectum, clean. Okay, let me see on the other side. I think it is completely clean, and I can cut here. Préparez-moi l'électrocardiogramme 12 and the Signa 60. So we'll cut here because we have any way to cut. Hein? Quel manche médium? C'est pas grave. No, c'est pas grave. So we'll cut here, and then we'll decide if the second section is done here by nose. So if we do, we'll do here a second section by nose. Then I think we can afford to do this suprapubically, a short resection from here to there, and to spare 10 or 12 centimeter of rectosigmoid. I think it is logical and better than carrying out a long segmental resection. Huh? Ah oui, have indicator. Je ne sais pas utiliser indicator. Signal. Yeah, we'll cut here like this. Okay, now until Barbara comes, let's go on the sciatic nerve, and we'll follow the more or less the 10 steps I have already described in a video article in I think it has it's published in Journal of Minimal Invasive Gynecology, where I describe 10 steps to remove an endometriosis nodule of the sciatic nerve. The first step is the incision of the peritoneum so here we do not have an endometriosis of the sciatic nerve, but we just go to try to understand if the sciatic pain, which is recent and which is cyclical, is due to a vasculoneural conflict. So we open the peritoneum on the level of the external iliac artery and vein, which is here, you see here, and we will also identify the genitofemoral nerve, which is here. Okay, I need now from since I published this article, I changed more or less my approach, and I do not longer use so frequently the dissection outside the vessels. I am working more medially, but as here I do not, as here I have some fat tissue, I think I will, and I want to do a didactic procedure, I will also open laterally, and you will see when it is useful to have this lateral opening. So you have here the external iliac artery, here you have the round ligament, here you have the psoas muscle, and just below you have the vein. Here just is the vein. So we will, here is the vein, you see, in blue, and we have to go down, and the next anatomical structure will be the obturatory nerve. Okay. So we preserve the genitofemoral nerve, otherwise the patient will have unpleasant anesthesia of the tide. Yeah.
Is there a place for the operation with MRI to see the sciatic?
Yeah, I did it. We have no endometriosis of the sciatic nerve seen on the MRI. So if the patient had not the indication of the put your instrument here like this, had not the indication of the surgery for rectal endometriosis, I don't think I would have indicated the surgery just to dissect this. So I dissected because I am anyway here, and I want to make sure that after the surgery I don't need to come back bipolar, to come back again. So here is the obturatory nerve should be here. We have some fat tissue. The problem with the fat tissue is that it hiddens the anatomical structure and has the tendency to bleed. That's why we have to go slowly, otherwise we'll have bleeding. Here we are on the lateral side. Last Friday, we did a very huge nodule of endometriosis of the sciatic nerve with Matan. And there the sciatic involvement was obvious. Just let me this fat tissue, because the obturatory nerve is inside. Obturatory nerve is inside. The problem is that we'll have some bleeding here. So the obturatory nerve is inside. And just below the obturatory nerve, we'll have the obturator vessels. That will cross our operative field. You see here is the obturator nerve in white. You saw it here. Here. When the fat tissue is less, the dissection is much more pleasant. The goal is to identify the lumbosacral trunk and to dissect it until the sciatic notch to make sure that I do not have a vein or something which may explain the pain by cyclic dilation or something like this. Okay, you can leave. Leave it. Let's go on the other side now. Hold this like this, please. Okay, now we'll open here. Usually it's better to open, to cut the round ligament because it opens larger the field. But here I will try not to do it. Here we have the obturatory, the umbilical artery. So we have to go on contact. Again, the fat tissue is, and here we have again the obturator nerve. So hold please the umbilical artery, my friend. Yeah. Now I'll cut here the fat tissue. medially, laterally from the umbilical artery. Okay, and here we are again on the obturator nerve. And the sciatic nerve is here into the depth. So we will see it here in this. It is in laparoscopy. We see it medially from the obturator nerve. Okay. Bipolar. Could you clean a little in order to? Yeah, perfect. Now here we see a vessel. It is the obturator artery, obturator vein, I want to say. It may be very large, and we may need. Usually, we need to clip it. Otherwise, there is a risk of bleeding. And you see, we have vein here. The veins are ça va. So I will stop a little because my colleague Dr. Noiret is here. We stop and we come back in a couple of minutes. Barbara, look, Liv. We have two nodules. So we have the rectal nodule, which is here, which is too large to be removed by disc excision. But the second nodule is very far, and it is subocclusive. Look at the dilation above. Yes. So what I propose, instead of 25 centimeter resection, do you think it is feasible to perform a rectal resection here by nose and to remove only this short by this tuck here and to conserve the 10 centimeter of rectosigmoid between? Yes, two resections, not two excisions, two resections. Because here we can pull this up and do it by hand, the suture by hand, and then to pull it inside and to do the resection. So this colon, if we can conserve it, it would be better. What do you think? The ICG? But we have not ICG on this. And second one transabdominally. Yeah, because it is too far to use the transanal stapler. And I would like, if possible, to spare, you know. Do you think it is feasible or reasonable or not? We'll cut very short here. So I did only the mesorectum at the level. Here we do not touch. And this we pull it up. We dissect only here to release here, and we pull it up and we do the... Huh? And in this case, the sequence will be resection here, and then nose, in order to, because if we do this first and we pull it, we'll make a traction on this suture. Okay? Okay, very well. We do this by hand and this by nose. Huh? So we do this by hand, right? End to end by hand. She asked if you use PDS or what else, or Vicryl. What is the thread you wish to use? PDS. Okay. In this case, I will finish with the sciatic. Then I will cut this. Then I will call you to do this and then the anastomosis here. So you stay a half an hour. Okay, and I will call you maybe within, let's say, 45 minutes. Okay, very well. Perfect. So our decision is we finished the story with the sciatic. Then we do the nose, but without performing the anastomosis. Then we carry out the suprapubic incision. So maybe our connection will be finished. We do the suprapubic incision with the hand by hand and end-to-end anastomosis. At the end, we do the anastomosis here. Okay? I think is the best. Okay, hold this because I need to open a bit here. Bipolar, please. I have to take care to the external iliac vein because it is here. Okay. So here we are on the internal iliac artery, ultraincision. Of course, the easiest would be to carry out a long segmental resection, but I think we take a risk of Lars, and honestly, we can avoid it. I think we have at least 60 patients with this kind of two procedures on the rectosigmoid, on the sigmoid and the colon, sigmoid and the rectum, and honestly, we are satisfied by the outcomes. Harmonic. Okay. Bipolar. So here we have to identify the obturator artery and vein. So the obturatory vein, we saw it here. And there is fat tissue, which is not very pleasant. Okay, we may put a clip here, a big clip. Oh yeah, hemlock, okay. Okay. We put a hemlock to be able to cut it, then the number one. Okay. Bipolar first. Bipolar to see if I hold everything or not. Okay, scissors. Okay, bipolar. Okay, let me see, and here we'll see. So here we are on the lateral wall. The spine is here, and then we come back, and you see here is the sciatic nerve. Yeah, here is the sacrospinous ligament. Okay. Okay, very well. Now, give me the bipolar. Bipolar, and now you have to stay right because I need to, yeah. So we have the sciatic nerve here. Here is the sciatic nerve. So let's see if we have something which may compress. Here we have this okay, come back, aspirator. So here is the sciatic notch. Now let's dissect a bit retrogradely in order to open our space here. Bipolar, bipolar. It's a small artery. Okay, and here we have again the lumbosacral trunk just below. It would be maybe better to clip this. I think a clip will be enough. Here, or maybe let me see. Put here because I want to see if I put a clip or I put a hemolock. We'll release all this stuff because I think it may compress. Why not? Tick tick tick. Give me please. Oui. Yes.
No, it's very interesting to note that the audience is completely silent. This is because maybe I think that everybody's so anxious, everybody's sweating.
Clip. But what is anxious that we can injure a vein? Here, I think 50% of this procedure is taking care of vessels, because any injury of non mais un hémologue je veux hémologue. because any injury of vessel here requires coagulation, which usually does not work if you injure a vein. And then if you coagulate too much, I will simply have a heat diffusion to splanchnic nerves and the bladder dysfunction. Another. That's why it's better to not to have any bleeding. Now, honestly, with when you have an endometriosis nodule, the dissection is much more aggressive because I know what I am looking for, and it finished by sectioning all the vessels. And in this case, it has happened Friday. And in this case, the sciatic nerve and the sacral plexus and the pudendal nerve are completely free and visible, as you can see them on the anatomical model. But here, as I am looking just hypothetical conflicts, so I cannot afford to do the same dissection. That's why maybe the visibility of structures or less, and I think my colleagues, fellows can testimony this because they were there Friday, and I don't know if they feel that we have the same surgery and the same anatomical structures because they see them differently. Here we have another vessel, and we have to put a clip on, and I think it is just a moment. I have to separate it from the just a moment. Yeah, like this. Yeah, here is the vessel. Okay, I see. Clip, hemolog. When I do clip, it means hemolog. And when I do hemolog, it means clip, you know. Okay. So here we have a vessel, another one. But honestly, I think there is no conflict because there is no the. Okay, aspirator. So this is, you see now the sciatic nerve is here. You see it very well here. And the pudendal nerve is there. So section. I have never had injury of nerves, of the sciatic nerve, never. I had a very sad history on the femoral nerve, where the patient has the excision of an endometriosis nodule, and at the end had the palsy. The palsy was impaired by the surgery, and I think as I did not cut the nerve, I think there was a ischemic mechanism or something like this. But on the sciatic nerve, honestly, until now, patients have already been always been improved, and I have already done maybe 200. But I am prudent, and I release the sciatic nerve. I try to see it very well. In most of cases, there is not actually an infiltration, but even in patients who had infiltration, the outcomes were favorable, thanks to God. Here I have a clip which is gone, but fortunately, come. Fortunately, I coagulated the vessel. Yeah. Huh? She told me that she moved the leg, of course, because the sciatic nerve is here, but it is completely free, you see. There is nothing here, aspirator in the middle. So let me show you it again. So get back. So we have anatomy. So we have psoas, genitofemoral nerve, I missed the name, external iliac artery and vein. Then we have the obturatory nerve, and then 1.5 centimeters down we have the sciatic nerve. To see it, usually we have to take it, Aspi. We have to cut the obturatory vein because it is in the middle. And here you have the sciatic nerve here. And Milen, my nurse, tells that the patient is moving the leg. Of course, this is the sciatic nerve. And this goes out. Here is the spine. Here is the sciatic notch. And here we have the sacrospinous ligament. So if you want to go to cut the sacrospinous ligament, we'll identify the pudendal nerve here just below. So I have to cut this to see the pudendal nerve. It is there, okay? So I think that we do not have we cut this fibrous tissue. I don't know if it helps or not in sciatic improvement. You see the endometriosis lesion is not far. It was there, so it is not far at all. And here we still have, so I will also cut this because this is still endometriosis on the parametrium, and I think this can be responsible for pain. Just grasper. So let's remove this. Here there is still endometriosis, and to do this we will come here and we'll dissect, hold this, and we'll dissect the internal iliac artery and vein. Come here. In order to make sure that we do not have an injury, because when you cut here, you may fall on, you may cut veins tributary to the internal iliac artery, and this may create hemorrhage, which requires coagulation, and any coagulation in this area means you burn some splanchnic nerves, and at the end you're surprised that the patient does not void the bladder, because you say, I did not cut anything. Yes, you did not cut, but you burned them. So that's why I always come from the middle. I try to identify, I achieve to identify the internal iliac artery and vein, which are right here. And this approach to the medial parametrial nodules is described in a novel article I published in Fertility and Sterility, Ultracision, in Fertility and Sterility 4 to 5 years ago. It shows how you have to dissect, to start by ureterolysis, then by Okabayashi space, then by the dissection of the internal iliac artery, you see here, and then the internal iliac vein, which is just below, hold here. And then we go progressively distally. We go progressively distally. Here is the vein. Here, just below. We go distally in order to identify which are the vessels which may come in contact with the posterior limit of the nodule. So the internal hypogastric plexus is here, so we try to push all the vessels here. You see here are splanchnic nerves. We try to push them laterally, but at the moment we have to cut some of them because they will come in contact with the nodule. And if we have to, yeah, so here we will cut this. The ureter is here, and we have to go down because the inferior limit of the nodule is here. So hold this now. Hold this part of the nodule. Can you clean? Because I think the view is not very good. No, again. But do just once like this. You go from down to up. Like this, okay? Okay. So I think the sciatic pain is maybe due more to this lesion, which comes not far from the sacral plexus. The sacral plexus is simply below the veins. Yeah, here is. Okay, now come back here. No, don't hold this like this, and just come with the endoscope to show me. Je peux avoir bipolaire? Just let me clean. Okay. So the nodule should come more or less here in this area. Here we have a vein. Yeah, here looks to be the inferior size. Here we have fibers from hypogastric nerve here and there, but it will be difficult to conserve them because here they come on contact with. Let's try to do, but I will injure them by the heat. As I told you, there is a sympathetic nerve, so it is not responsible for bladder voiding, but for information, for detrusor relaxation and information about the bladder filling. Yeah, here. Okay. Here we'll remove this. Okay, here we have. Very well. Now hold it up and stay right with the camera. Yeah. Okay. Let it me leave it. So we have to remove this. So this is okay. Okay, here I think it's the limit between the healthy and the sick. Now hold this and put it laterally. Laterally, medially, I want to say. Okay, aspiration. Aspiration. So here we may have some vein below because we arrive at the level of the venous network. Yeah. Clip. No, don't let it. Hold, because I saw where is the, you see the hole is here. I have a small vessel with a hole here. It's not alone. Okay. Okay.
Est-ce qu'il y a possibilité de décaler un petit peu le tuyau de chauffage sur le... Ouais.
Okay. Okay, but it looks good. Medially. You continue to turn around. Very well. Okay, now up. Okay. Very well. Once we did this, we go on the notes. Very well. Down. Because now I need to come here. Okay. And here we are back on the vagina. And here in contact with the rectum is here, okay? Very well. Put it into the vagina, please. Don't move. Not let it. Put it here. Let it there. Don't tell it. Don't take it. Come. We have to do the hemostasis here. Show me where I have the bleeding. Okay. It should be a vein from this side. I have to put the ureter far. You see the ureter is pushed laterally by my aspirator. Okay, just a moment here. Again. Okay, we do not longer move. We do not longer touch there. Perfect. Now hold this out, please, the nodule, and then during the time you hold the nodule, I will put a 12 millimeter trocar in order to to carry out the resection, the section, distal section of the rectum. I have already prepared it, so I have just to cut. Okay, very well. Thanks. So I will use Signia 60. Okay. Now, pince. Matan, you have to... aspiration. Okay. Ok. Il faut mettre parce que j'aurai besoin. Hein. Ah, l'autre un. Oui, c'est quoi un autre?
Soit une autre éléphant, soit on prend celle que...
Celle qui fuit? Non, je veux pas celle qui fuit. Mais je l'ai pas voulu tout à l'heure. Pourquoi je la voudrais maintenant? Okay, just a moment. Yeah, like this. Okay, I am below. I am below. Yes. Yes, I am below. Very well. Clean, please. Very well. I will need the second one for sure. Because it will not be enough with only one. The rectum is large at this level. So we step out with 3 rows and then we cut. Okay. And now let me see. I think we have 5 centimeter to 5 millimeter to 1 centimeter. Pull the You see, I have to cut here. The suture comes until there. Now on the overside, because I need to see where is the limit is here. Okay. Very well. And push on the overside, the rectum. So, yes. And now you can come close because we have okay, let's go back here to see that everything is okay. Come down. So the suture comes here, and yeah, I'm on the right position. Perfect. Now come back with the camera. Pull the rectum. Yeah. And now I will staple safely without ureter, of course, without nerves. And this time will be great. Great. Okay, so here we are okay. The rectum is clean. Very well. Now you can leave it. We need to see what we cut. So we have to cut until there. Hold this. So I need to release just a little, not too much, in order to make sure that the vascularization will be okay. Okay. On prend une 31. PCE1. PCE1. EA. So we'll take an EA anvil. We'll put it inside. And then I will place it. I will cut the column and we'll place it. We'll place the anvil here. And then I will call Barbara to carry out the suture, and at the end we'll finish by the anastomosis. Hold this. Up. Yes, so we have to cut here. Ok, just take the camera, please. Il faut que je libère un tout petit peu. I just need to release a bit in order to not to have tension on the anastomosis here. So I will cut just the peritoneum and not the vessels. Yes. So after the surgery, the patient this surgery will have 2 sutures. However, we do not longer perform stoma, preventive stoma, because we understood that it does not prevent anything. We leave the patient without stoma, and we attend her very, very closely during 10 days with daily CRP and white cells. And if from a day to during this time the CRP is expected to decrease slowly as the white cells decrease. And if we have an increase, sudden increase, we call the patient back to the hospital. We carry out vous avez l'enclume? We carry out a CT scan and maybe even a laparoscopy in order to make sure that we do not have a fistula, and only if we have a fistula, only if we have a fistula, we do the stoma. Take this and be ready to come to take the specimen. Now I will cut the rectum, and my colleague will be ready to take the rectum out. That's why the procedure is called nose natural orifice specimen extraction. Okay, so let's move the anvil because it is let's put it here like this. Okay, now come here with the hold the extremity and put it up. The extremity here, the extremity of the, put it up. Yeah, very well. Now hold it. And now we'll cut the colon here. So we are very, very economic. We try to cut at 1 centimeter far from the nodule in order to spare as much as we can the bowel. Now this patient, I told you, I carried out an MRI. The MRI is mandatory. And pens, usually, is mandatory in order to know exactly what you have to do. Now we are about to look for the place, to identify the place of the new salivary test, which we use for the diagnosis of endometriosis. And no, up, because here it is open. I have to close first this. Just a moment. Yeah. Okay, leave it now. Come with the grasper, open the grasper, put it in the middle of the grasper. Yeah, open the grasper. Okay, get out. Perfect, thanks. But I think for a while the MRI will be a major exam, and I think it was a revolution in the understanding of the deep endometriosis. While the salivary test, I think, will be a very good solution for patients with... mais vous l'avez pris au bout. Non, mais il faut le prendre à côté de l'aiguille. Mais non, c'est bloqué. I think the salivary test will be much interesting in patients where the MRI is negative or expected to be negative. Je peux avoir notre deuxième porte-aiguille que je suture correctement. because particularly in adolescent where the MRI is not contributive, and in this case we do not know how to manage them, and I'm sure you have a lot of patients like this, particularly adolescents which mother had an endometriosis and is threatened by the possibility that her daughter has one too. Do you have the salivary test available in Israel or not? Yeah. Yeah, but I think now in a study is ongoing in hold this, my friend, please. A study is ongoing in France because I think in this case it will be very, very interesting. Because in this patient with big nodules of the rectum, of course, the salivary test is not interesting. We know she has an endometriosis. But in women with negative MRI, we are a little blocked. We can either perform a laparoscopy, and if the laparoscopy was not done by an expert, we always wonder if he actually saw the lesions or not. So sometimes she had the second laparoscopy by an expert. So I think the indications will change soon during the next years. Anyway, I feel lucky that I have lived during this period of 2030, because I think it is a fabulous time for endometriosis. Leave it. Fabulous time for endometriosis. When I think about the years 2003, where I was resident, but I was not aware about endometriosis. I heard about endometriosis only when I was in the last residency year. This is impossible to imagine this today. Babcock. Now I will put the anvil inside, and I will ask Matan to keep it blocked inside. Hop. Now, Matan, leave this and hold the edge. Yes. No. Yes. Hold the edge. We put the anvil inside like this. Now leave the edge. I will give you the Babcock. Remove the grasper. Remove it. Remove the grasper. Hold this and hold the anvil. Hold the anvil. Okay. And keep it, and you will turn right and left to show me the best, the edge I am working on. Okay? We have already done this together Friday in the patient with sciatic nerve endometriosis, but we did it on the robot. So it's the first time we do it laparoscopically. So I am carrying out a pull string. You can tell Barbara that she can come in 10 minutes.
Professor Oman, are you still left alone to consider the mental flap?
Yeah, it's a very nice question. So you have to know that until 2018, I was systematically doing the Omental flap. And when I arrived to Bordeaux, I definitively stopped. And so when I arrived to Bordeaux, I stopped three procedures: the stoma, the preventive stoma, and the omental flap. And I did not see, turn to show me the edge. Yes, like this, perfect. Yeah, hold the white, please. Yes. And I did not observe any difference. And I think the omental flap, if you put it right now, it does not actually prevent the fistula, but if you have a fistula and you repair it, the omental flap is useful. So I do not longer put it, I just leave it to 3% of patients who may have a fistula and who need to repair it. Hop. This is nice. Okay, so I think we are close to the end of the life surgery. So do not worry, because I will put, as I told you, I will put it on YouTube, so you can see the end, the last hour or 45 minutes, because you do not have too many things to do. We have just the suprapubic incision with the anastomosis end to end of the sigmoid colon. Then we'll pull inside the colon with the anastomosis, and very well. And then we'll simply do the colorectal anastomosis, and then I will close the vagina. Thank you very much for inviting me. I was very pleased to have Matan with me, and we are lucky to have him with us for 6 months, for the next 6 months, and I.
We will try to manage without Matan, although it is a little different.
Yeah, and if you go to ESG, I would be pleased to meet you there, because I will be in Istanbul within 1 month.
Thank you very much.
Thank you, and have a very nice congress. Congratulations to organize the first conference in endometriosis in Israel. It's a very good news. Thank you. Okay. Ouais. Coupé, oui. Ouais. Quitter la réunion. Yeah. Fin. Plus long. Ah là. Quitter. Ok. Oui, bien sûr. Ok. No, best, yeah. Don't come it, put it far, because I'm too close to the... Okay, yeah, you have to pull it. I need to see there. Yes. Quelle poche? Okay, no, leave it. Okay, it's okay. Maybe it's better like this, because I can do it better. Be ready to take it if you see that it goes inside, not to lose it. Okay, now turn. Yeah. It was okay? The live? The view is less good and then with the robot. Yeah.
I'm very happy they managed to see the sciatic nerve.
But you see that the approach is different because when I go for a nodule, I cut all the vessels, so you see them differently. When you're not sure what you're not aware what you find, or if you find something or not, you cannot do the same huge dissection. Okay, leave it a moment. Okay. Saribulos, you know him? Sari. But he's from Israel. He's Arabic living in Israel. And he spent here 1 year. And yesterday he said, oh, I will be in the room. And I just think that 2 years ago, I was on your right instead of Matan. Yeah. And 4 years ago, there was Ahmed. And 2 years ago, Alex. I think Alex arrived immediately after Sari. Sari was just before. Sari left in 2003. Sari was here in 2002, 2003. He was here when Violet was sick. Yeah, I know. Okay, take this. Take the white. If okay, turn toward me. I need to clean the fat tissue. Very well. Veloc, hein? Oui, veloc. Turn because turn, yeah. Ouais, elle vient, Barbara? Vous l'avez dit? Non, on va pas voir trop bien. Not always. That's I told that if the patient has another surgery, I do it. But if she has not another surgery, it depends. Another transport. sortir ça. It depends. If the patient has obvious symptoms or vascular conflict, for example, she has a lot of on the MRI, a lot of pelvic varicosities, vein very dilated, and she say, come closer. And she said, I have pain more in the evening, and I have never pain in the morning when I wake up. We can think that the standing up increases the pain because increases the volume of the. Pourquoi il est éteint? Ah, vous pensez qu'on n'a rien enregistré? C'est OK ou pas? OK. Now push, leave it, and let's do the suprapubic incision. I have, yeah, that's why I think I think it was interesting because you see the risk to have to miss the lesion. Second, this is the decision which is taken with the goal of preserving the function. Just we have to come here because I have to increase the huh? Genitofemoral nerve is, let me see, it's here. This is the bandlet of the psoas. Huh? Oh, who?
Everyone that was here. This is 10 best surgeons, I think. No one was here.
I think it's okay. I think it will move. Okay, very well. Now let's incise. Vous voulez qu'on mette la caméra externe, mais amène la caméra externe, on va voir. Have to bring it from the other side. So we'll do this suprapubic incision simply to do the proximal resection. Il est où la monopolar? Ici.
If you want to assist to torch, you have to change your glove.
Can I take it?
Oh, you need another
8 number.
Hmm?
what is it, 7.5?
8. 8. 8. Yes.
So we incise, we do a short suprapubic incision, 4 to 5 centimeter. You just have to take care not to stay in the front of the camera, which is there. Yeah, you stay in the front of the camera. It's not a good idea. Sit down, because you're in front of the camera. It was not a good idea, which is not amazing, because it was not my idea. It was the idea of Milen. Mm. Okay.
Après, on peut essayer de prendre avec la poignée. Elle tire au max.
Ouais, elle n'a pas beaucoup d'amplitude. Okay, now you can stop inflating. So you put an Alexi retractor. Like this, okay. Okay, and then you have now to leave your place to Barbara. So I put the I put the anvil laparoscopic, and now we have here the. I could do it by hand. So here is the lesion, you see. It's a very stenotic. Yeah, we have, and we can do it very shortly, huh? May we bring the over light here? This light. Just don't touch this. Put it down. Put it down. Bring it down. Down, 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 down. Okay. Vous avez pas encore un. Yeah, it's much better. Si, on a ça aussi. We have the harmonic.
Bah non, en fait, désolé. Réflexe. I thought that MRI's 2 notes was very close.
No, it was not. In MRI, I said it should be a 20-25 centimeter high. But you know, fortunately, they will have the MRI because it was so far that it can be missed easily. Okay. Tiens, on peut couper.
Ah oui, le liquide, ce sera à la fin. Pardon, très bien. Ce sera à la fin quand j'aurai fini l'anastomose, juste pour la marquer.
Okay, so we'll cut with cold scissors the bowel, the sigmoid colon. Proximally and distally. Enlevez ces compresses là parce qu'ils nous volent la lumière sur.
Ok, tu vois. T'as une de baquet?
Well vascularized.
Yes.
Very well. Okay. Okay, perfect.
Ok. Alors, il m'en faudra 3 de PDS 4.0 s'il te plaît.
So we do 2 hemi-running suture, 2 hemicircular running suture. Ah, pourquoi, regarde, qu'est-ce qui s'est passé?
T'as une chute peut-être.
Marion, on n'a plus d'enregistrement, il n'y a plus de lumière, il n'y a plus rien.
Est-ce qu'elle est bien allumée là-bas? Ok, je vais te prendre une deuxième PDS.
Non mais la caméra il marche plus. La caméra il marche plus.
C'était en échange. Merci. C'est allumé. Je vérifie si le signal passe bien là, au niveau de la porte SDI et du boîtier. Hop, je prends une Kelly échappée aussi. Et là, un autre PDS.
Mm.
s'il te plaît.
So explain in English everything you do.
Ah oui, of course. Sorry. Hop. Ok. Ah, sorry for the finger.
Aïe.
Okay, so I will begin by the posterior wall.
So we start by the posterior wall, the running suture.
With PDS.
And we do this instead of side to side stepless in order to spare the bowel and to have a peristaltism which is straight. Mm. Hein?
De quoi?
De l'eau bénie du professeur? Non?
La peu bénie. Ok, je peux me tenir.
Non, ça va. Ça filme toujours pas?
Si, ça filme.
Si.
Ah, il voit? Ouais, ok. C'est pas, il n'y a plus de live.
Oui, mais on enregistre parce qu'on va faire le film jusqu'au bout. Hein. Ok.
So the most important to take the serosa.
The serosa
Yes.
and the mucosa?
And the mucosa, yes, but the most important is the serosa.
Okay.
Tu peux juste me déplier la compresse, s'il te plaît.
Content told me that thanks to you, they will have an incredible SIGAPS point number this year.
I don't know. Yes, we published some a lot of articles today this year. More than in Lille.
Monday?
In Lille.
Ah.
Yes. It's pretty difficult to publish some articles.
Have you known Mariette?
No.
No.
My first year in my internship when I was a resident,
Mm.
but after he died, unfortunately. But it was a great surgeon, very brilliant.
And scientist.
And scientist, yes, in oncologic surgery. I think thanks to him we have improved.
Okay, so it gently progress. So that's why you see we have to pull the colon out. That's why we started by this suture, because if you do the anastomosis first, we pull on and we can fragilize. Yes. So the second C should be respected. And I understood this immediately once I did this surgery in the other order, and the patient had a fistula.
You learned it the hard way.
Yeah.
This is the 3-0?
4-0.
4-0?
Yes, 4-0. PDS.
So here we completely finish the posterior hemicircumference.
To be sure that I take the server. Okay, you can leave it.
I leave this.
Yes, I leave. Just.
Do you have to
this
remove
one.
or?
Yes, just remove this one. Okay.
Yes.
Okay.
I put on both.
No. Which
You
one
want-
was the last one? This one.
Yeah, this one.
For the IPG?
Okay. This one was the last one.
This is the last one, yes.
Okay.
But to see, we have to switch off all the light. Mhm.
You received the IV?
But when you see how it bleeds, I don't. I'm not sure that it is actually very useful. Maybe to see the other one inside. Okay.
You can take. No, no. I will. Okay. Can put. Yes.
No,
Okay.
je crois pas. Ça m'étonnerait.
So I will start by this one.
Now we go back on the anterior hemicircumference.
So after the surgery, how many days she avoid eating?
She eat this evening if she wishes. Usually they do not. Yeah.
Extreme.
Usually they do not eat the same day because they are a bit nauseous about after the surgery. But if they wish, they can.
She won't eat a cheeseburger because it's
Yeah.
evening, but she can eat this.
A small choucroute, it may work.
Good cheeseburger.
Non mais j'ai pensé que si Ashraf vous a invité en Égypte, vous pouvez aller faire un petit cochon de lait. Parce que c'est sa spécialité. Non, mais là, dans sa tête, elle déjà se voit l'assistante de Philippe. C'est pour ça que maintenant, il sort des instruments très fins.
Il a voulu me débaucher, il m'a proposé un salaire mirobolant. Bien sûr, tu lui dis non.
Elle réfléchit encore.
J'attends qu'on va se battre pour moi, mais
Ouais.
il dit.
Elle attend que j'ai plus, oui.
T'attends que t'aies peur, hein. On peut mettre une petite pince là-dessus.
Yeah. Okay. And now we'll come from the other side.
Yes. Tiens, je peux te donner ça, parce que désolé, comme ça tombe, je te donne un peu. Ok, est-ce qu'on a un ciseau?
On a fait l'indocyanine ou pas? Non. On va finir la suture, je pense.
Je pense que ça va aller, non? Je sais pas trop de...
Mais non, vu comme c'est vascularisé. Non, mais on va regarder l'autre. Hein. On va regarder l'autre extrémité. Okay, so we have the ICG, external ICG, so we'll check the vascularization, but there is no doubt about the vascularization of these edges because you see they bleed easily. They are pink, red. Hmm? Yes. Okay. Okay, very well.
Okay, can you...
So, last knot. And the anastomosis is very nice, vascularized. On a injecté la ICG? Okay.
Do you want the camera to take
Yeah. Yes, but just a moment. We have to remove the light. Just a moment. I will show you.
Oui. Oui.
15 minutes, ça va être bon. Just a moment. So, okay, switch on. Yes. Beautiful.
One more cheese.
Yes. Just I will do it this. I will do it this. Okay. Yeah, it shows that it is green and even very, very green. No. Yeah, It's okay for me. Change maintenant. Pas eu le temps. Je peux avoir des gants?
Oui, non, mais j'ai inversé.
Sorry.
Est-ce qu'on peut mettre des petits clips métalliques? Ouais, c'est bon. Ok, I put some clips.
Tu mets où ici? Mais monsieur le fil.
Yes,
Non?
le fil. Il est déjà chargé ou pas?
Ouais.
Ok, so I put some clips just in case we perform a CT scan and we can. C'est là. Voilà.
Okay.
We can see both of the anastomosis.
Scissors. Okay. Scissors. So you put clips just to know where is the anastomosis.
Yes.
Do you want me to look for the other one if it is well vascularized? And maybe to just to check the. Can you antevert the uterus, please? No, because I did not mobilize too much.
Too low to come
It's
up.
too low, yeah?
It's too low, and I did not mobilize it too much. So let it
okay.
like this.
Yes. I think it's too deep to.
It is too deep to see.
Okay.
No,
But I think
just
it'll
one.
be okay. You let the meso.
Yeah.
Yes. Okay.
Okay. Now let's put the occlusive. The head. Yes. You should come on the side of Matan and continue to antevert the uterus during she works. Yeah, you can. Okay. Wonderful. We'll put this here.
C'est dégonflé normalement.
C'est là, c'est dégonflé?
Je vais dégonfler avant l'incision.
Ok.
Par contre, il faudra faire gaffe parce que vous allez voir, on a le.
Ouais.
Non, ça va, j'ai appris, c'est gentil.
Okay, it will be okay now. Inflation. Marianne, il faut que tu retires le caméra parce que c'est devant mes yeux. Okay. Okay, so let's see how it presents. Okay, very well. So here we have the anastomosis. Grasper, please. Grasper, just a moment. Gently. Hein? On a des pertes énormes. On ne devrait pas. Oui, mais même, on ne devrait pas avoir ça. Ok, mais donnez-lui. Non, donnez-lui la pince et on y va. So we'll put the grasper, the ear stapler. We put the EA stapler. So here we do not have blood, very well. Okay, now antevert. Just one, come. Here is the suture. Mais je comprends pas pourquoi ça compense pas. Qu'est-ce que ce bordel? Pourquoi ça compense pas? Tiens, come Matan here and hold this like this to block. Just one. Up the uterus. Up the uterus. Hold this and put it like this to block. Okay, very well. Okay, I think if you I crossed the sutures here, but I crossed the suture there, you see, but it's a bit lateral. So I think if you come here, but try to put it just below the suture, it would be wonderful. Yeah, here, like this is perfect. You can come. Yeah, okay. Great. You want me to clean the fat tissue below? Maybe a little. Hold, please, the camera. Okay, now let's come with this. Let's see if the yeah, it's okay. The suture is still okay, very well. And now I will come with this. Very well. So we have the distal anastomosis. Great. And look at the distance to the second one. This is 10, I think is at least 10 centimeter. 10 or 12. Mm. It's perfect. There is no tension, nothing. So we check the donuts. Complete? Yes. Perfect. So now we'll check the anastomosis with her. Réduisez le train, s'il vous plaît. Tu fais à l'air? Ouais, fais à l'air. Ouais, c'est bon. OK. bubble test. Et après, dis-moi à quelle hauteur elle est. OK, bubble test. Perfect. No bubble. No. And the height of the anastomosis is, I think, 8 to 9. 8 centimeter. Perfect. Yes, at least 20. Okay, thank you very, very much. Now, my friend, come between the legs. And we have the last step, which is the suture of the vagina. Tu peux la mettre encore en train, s'il te plaît? Okay, the V-lock, please. Okay, hold the camera, please. On va le mettre par là. Okay, merci. Okay, and now I start suturing. We do not longer move. Merci beaucoup. Bye bye. Just push on the bowel, but do not pull it because there is a suture. Okay. Or no, don't touch it. It's okay because I can do it. From this moment, less we touch the bowel, better is. Okay. Okay. Ooh. Just I don't know what I want you to do. Maybe to hold the thread. To hold the thread once I do the knot. Yes, like this. Great. Get back. Each time I have to get back. Get back with the camera. I need to see where is the needle. Each time I have to get back with the camera. Okay. Don't leave. Why did you leave the thread? Take it like this. Okay. Take a distance. When I move the instruments like this, take the distance because otherwise we touch the camera. So when I pick the vagina, come very close. But once I come toward the camera, get back. Okay, get back, get back, get back. And hold the thread just very close, because now the thread is shorter and shorter, and I need the whole length for me. Very well. Okay, get back. Perfect. Hold. Get back. Okay, come close. Get back.
On peut faire descendre la patiente.
Okay. Come closer. Close, close, close. Back. Leave. Okay.
Il y a un point de.
No.
Il y a Frédéric de Rouen qui vous embrasse. Vous n'avez pas donné le nom.
Comment vous l'avez?
Il y a quelques semaines qu'il vous donne régulièrement de nouvelles.
Non, c'est gentil comme toi. Elle est adorable, cette fille.
Vous savez qu'elle est venue en gynéco.
Ouais, elle est. Donnez-moi un clip ou un. Vous avez encore un hémologue ou pas?
Les pompes, non, j'ai les clips qu'elle a utilisés.
Clip, clip, clip. Donnez-moi. Ouais. Ok. Scissors. Okay, very well. I think it's finished after 3 hours of fight. À midi moins 2, je dois être dehors. Mhm.
Dans 6 minutes, vous avez fini.
La ponévrose. Okay, thank you.